So today I'd like to talk about psoriasis, and I think that's something that a lot of people know something about, some people know more about, but really impactful for those people that it affects. And psoriasis does not just impact the skin, which is really important to know. The objectives today are to basically kind of define psoriasis. I'll show some pictures, the extent of disease, and disease comorbidities that go along with psoriasis, some of the causes and risk factors, triggers, and then move on to some treatment approaches that would include, diet, lifestyle, as you can imagine, as well as supplements and medications. So what is psoriasis? Psoriasis is a chronic skin disease affecting about 2% of the population. Symptoms can start at any age, peaks often between 30 and 39, 50 to 69. You'll see those numbers vary pending the source that you look at. It tends to be less common in children than adults, but is not unheard of in children. It's a chronic inflammatory skin disease, and it is an autoimmune process. So it's characterized by keratinocytes, which are skin cells. They proliferate and build up, and there's inflammation. And basically, instead of shedding these layers, they accumulate and they end up getting activated. So the skin thickens, it builds up, and that skin is often like itchy and burning. It can sting, and so it can be relatively uncomfortable for people with psoriasis. The most common is chronic plaque or psoriasis vulgaris. It really accounts for 85 to 90% of all cases. It generally presents as well demarcated erythematous plaques with overlying scale. And I'll show photos next. Guttate psoriasis is numerous small plaques. These end up like little spots that we'll see. Commonly, I'll see them on the legs, but they can be really anywhere. Pustular psoriasis, really, I think people know what a pustule looks like. It's really a pustular eruption, and it can be a really acute, a subacute process, or a chronic ongoing process for people. Not uncommonly, people can have nail psoriasis, and so you get pitting, the nail plate can crumble, it can really thicken and become discolored. And then there's a small subset of psoriasis that's called erythrodermic psoriasis, and that's when there's widespread erythema, so irritation, redness of the skin, and if people have erythrodermic psoriasis, it's covering 75% or more of their body, so it's really significant. And just some pictures, you can kind of see here. Plaque psoriasis on the left, that's pretty common, knees, elbows. Guttate psoriasis, this is the little discrete spots. Pustular, that's when people get pustules, and all of these can happen anywhere. Inverse psoriasis is really not different, other than it gets its own category, and I didn't really give it a category because it's not a different subset really, other than it is on flexural surfaces. It's also the same thing, the psoriasis, that's what we could call it if people get it under their breasts or in their groin, in the axilla, behind your knee, those kind of things. Nail psoriasis, this is where you can get discoloration, you can get some spooning, you don't really see pitting right there. And then psoriatic arthritis is a real issue for some people, and it can look a bit like rheumatoid arthritis, so it can be symmetric, it can be asymmetric, a lot of times involving the hands, but it can involve other joints. So psoriatic arthritis is something, especially if we don't have a lot of skin issues, sometimes that can be missed, although, in terms of a diagnostic sense, but I hope to provide you the information to take away that you can see that there's inflammation is a commonality in the autoimmune process, the commonality for all of these. So whether you're dealing with psoriasis or rheumatoid arthritis, lupus, other types of autoimmune processes, there are commonalities at the root that we can address. So what's affected in comorbidities, you can see in those photos, certainly the skin is infected, nails can be affected, joints, psoriatic arthritis. In comorbidities, really obesity, metabolic disease, so diabetes, as well as hypertension and heart disease are often found along with psoriasis. Causes and risk factors. So this is one of those cases, there are some genetic markers and there is a predisposition. 40% of people that do have psoriasis have a family history of psoriasis. They do see it in twins as well. So one big thing that really over the years and going through the research, it's interesting, the further back you go, they go, well, maybe there's an immune reaction, we're not really sure. And really in the more recent literature is really immune dysfunction. It really has some roots in that immune dysregulation, T cells, which we talked a bit about in our immunity talk. And then there's these different inflammatory cytokines that get upregulated and cause problems for us. And when we talk about autoimmune, when we talked about immunity before, we think about leaky gut and how does that play a role in our body having basically maybe an imbalance in its immune response. In terms of behavioral issues, smoking, obesity, alcohol use are risk factors. There are drugs that can impact either impact or maybe be an inciting factor in psoriasis. Lithium is one of those. Beta blockers, anti-malaria drugs can be a problem. And then I have happened upon this with a few patients in years past post strep infections. So that's really interesting. And sometimes we'll do GI testing, and if we find strep at an overabundant percentage, sometimes treating that will improve psoriatic signs and symptoms, and can sometimes actually really impact disease. HIV would be a predisposing thing. Low vitamin D is a risk factor. And so super important. I think in most talks that we have shared, whether we're talking about supporting our immune health and our immune system, all of those things, bone health, it's vitamin D, vitamin D, vitamin D. So super important. Stress can be a cause versus a trigger. So stress is definitely, as we know, a big problem for really all of our long-term health if we are not able to manage it optimally. So this is where I kind of wanted to be able to just show some correlations. So chronic inflammation does play a role in most disease conditions, and we've talked about it with dementia. Certainly it's playing a role in diabetes, infections, psoriasis, eczema, colitis, so that's bowel inflammation, arthritis, cancer, and heart disease. So chronic inflammation is at the root of a lot of these things, which I think most of you really are understanding that, and that leads us to the importance of our diet and those things. One way to look at this when you think about boundaries of immune dysfunction and disease, so say our boundary is either our internal, so it's self, versus external, non-self, and then there's an immune response. So whether there's an excess immune response or a deficiency. So if we are worried about ourself and there's a deficient immune response, you can get cancer. Non-self, external, so if there's a bug and we have a deficient immune response, infection. So think about if our defenses go down and we end up getting sick, that's we maybe are lacking immune response. When we get into excess immune response, that's where autoimmunity, cardiovascular disease, and neurodegeneration, so dementia, those things all play a role. That's excess immune response to self. So something's causing our immune system to react to specific cells or receptors within our cells. And then when it comes to external responses, you're looking at allergy, atopy, hypersensitivity to things. So if we have an excess response to other things, say you have a birch allergy, you're often going to have a more robust response to pitted fruits and nuts at the same time that birches are blooming. So that I just feel like this is a good chart to kind of think about what's happening with our immune system. And then one important thing, and I'll talk about this some more, is a little bit when I mentioned immune dysfunction. So T helper cells, Th17 cells, mast cells we've talked about before, neutrophils are a white cell. all of these things, when we upregulate this interleukin 17, which is it's a commonality you can see in all these things, all these different things happen. We can get thrombosis. When it impacts these epithelial cells and fibroblasts, we get inflammation. When it impacts chondrocytes or macrophages, we can get cartilage damage. When it impacts osteoblasts, we can get bone erosion, we can get osteoporosis. So, the interesting thing is with functional medicine, when we look at roots, we can start to see like, wow, this one, if we can impact this, we can impact a lot of pathways. So instead of looking at disease entities as specific things, it's going further back and looking at commonalities and what are the drivers of those specific things. So I think it's just helpful. I don't want people to you could dive into this if you want, but I just want people to understand the concept of we can have the disease entities here, but also there's a common underpinning. And that's how we can actually treat things more effectively. In terms of triggers, stress, infection and illness, injury, nutritional deficiency, inflammatory foods are stresses, weather can be a stressor, and same thing here again. So I got a bunch of these slides from the immune module from the Institute for Functional Medicine, but triggers, when you look at triggers, we end up with this autoimmune disorder if we have that excessive response. And then look at what we're dealing with in our brain: MS, autism, Guillain-Barré, other psychologic things, our bones, arthritis, polymyalgia, muscles, we get into fibromyalgia, muscular dystrophy, and skin, eczema, psoriasis, scleroderma, vitiligo. Lungs, we're looking at asthma and Wegener's. Nerves, this autoimmune stuff plays a role in these neuropathies. When we look at our gut, we're looking at celiac disease, Crohn's disease, ulcerative colitis. In our blood, leukemia, lupus, anemia, dysglycemia, that gets us down the road of diabetes. And then in our thyroid, when we're having autoimmune issues, we're looking at like Hashimoto's and Graves' disease. So again, we're looking at triggers. A lot of the same triggers trigger this autoimmune response, and it can cause problems in all of these different places. So treatment approaches for psoriasis, a lot of them that have been studied, they have done some studies on hypo or low caloric diets that have been effective. They've not been able to elucidate, is it a weight loss phenomena versus the lower calorie? Mediterranean diet, it tends to be very helpful, and it's also anti-inflammatory. And high fiber, so I have a couple of slides on fiber, and we talked about fiber a couple of weeks ago and how important fiber is and how we can use fiber to modulate autoimmune disease and in particular psoriasis. Lifestyle, managing stress, supplements, vitamin D, fish oil, zinc, selenium have shown benefit. And then medications, we really look at topical versus systemic, and that really depends on the affected area and also like how much area is impacted. So topical clearly is going to be better for limited disease. It's also used in combination with systemic agents quite often, but topically we can use steroids, you can use emollients, lotion, petroleum, jelly, like different things to moisturize your skin. Vitamin D analogs are used quite often. Topical retinoids, those are also used in acne treatment. Tar, so people will use tar, shampoo and those kind of things to help if they have scalp psoriasis. Tacrolimus and pimecrolimus are a couple of other immune modulators. Systemic therapy, generally it's used if there's more than 5% of the body surface area. We can also use phototherapy. That can be really helpful for people. Methotrexate, we get into some of the biologic immune modulators, which also get used for rheumatoid arthritis and Crohn's and ulcerative colitis and those things. And I showed you IL-17, and so some of these immune modulators, they are actually tumor necrosis factor, anti-interleukin, particularly 12, 23, and 39 antibodies. So there's drugs that are currently being used and in probably phase 3 trials as well, focusing on things to work on IL-17. which is really interesting because that's where I showed you was that common underpinning in a lot of autoimmune disease. So lots of different things here. Clearly, diet is going to play a big role. And so there are, in my references, I have a lot of these different papers referenced in here. And some of the particular nutritional strategies for psoriasis, certainly, this is where I talked about the low-calorie diet, vitamin D, fish oil, selenium, and zinc. And there's also some botanicals which are pretty interesting that are used. And like this Dunalila Bardawil is actually, it's a green algae, and it's pretty interesting, like how some of these things can make a big difference. So, and curcumin, that's a common thing I think a lot of you are aware of. And, really they're stressing here, like we, as physicians and certainly like dermatologists, need to be working more with nutritionists when we start to think about some of these things. And for whatever reason, it seems that that not everybody's on board with nutritional management of a lot of autoimmune diseases. And hopefully we'll get there, because this is not like necessarily new information. And then I found some cartoons. I don't care what Congress says, that's no vegetable. And I thought that this was pretty interesting when we think about food. Lord, make us grateful for the cholesterol, diabetes, high blood pressure, weight gain, and indigestion we are about to receive. So really important to think about what it is we are eating for sure. And then I'm going to talk a little bit about the anti-inflammatory mechanisms of fiber, which is really pretty neat. So basically, if we add more fiber, you're getting less caloric density generally, and it will slow absorption, which lowers our glycemic index. It's going to improve obesity if we have more fiber in our diet. We think that there are some anti-inflammatory activities because of the structures of fibers. And then the other thing, which we talked about a couple weeks ago in our fiber conversation, is it really helps promote good bacteria, which directly regulates our immune system. We get more of those anti-inflammatory short-chain fatty acids like we talked about with butyrate, and we're going to be able to resist then colonization of pathogenic bacteria. So fiber is really great. And they talk about these polysaccharides in fiber, which can actually help our microbiota. And wouldn't this be great if someday we were able to stop eating so many vegetables? I can't seem to find anything wrong with you. So it's really pretty amazing what we can do with food and the opportunity that we do have. And then references, the National Psoriasis Foundation has some really simple things, and then you can really dive into a lot of different things about mast cells and inflammation. And New England Journal of Medicine has a psoriasis review, and mast cells and mast cell mediators as targets of dietary supplements. So those are those underpinning strategies we can use, nutritional strategies for psoriasis. Again, I used slides from the Institute for Functional Medicine Advanced Practice module, and then Up to Date is a good resource too. And I think as patients, you can access basic things on Up to Date. And then my last slide, I came across this last night and I was laughing probably for about 15 minutes. I kept giggling about this. The doctor saying, what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? So, we always have an opportunity to impact so much of our life and our health through the food that we eat and the choices that we make with movement and sleep and stress and all of those things. So hopefully this is helpful to everybody. And with that, I can take some questions. Let's see what we got.
Do you have a copy of the Mediterranean diet that you can give us?
There's not a specific, there is a great, there's a great book. Let me see if I can, Oh, what'd I just do? There we go. Good, I still got you. You know, I don't really have like Mediterranean, um, I don't really have like a handout, so to speak. I mean, I guess I can let me show you again. I'm gonna share my screen again. Share screen. So when you're thinking about a Mediterranean diet, you know, you're really looking at, oh gads, where's their little pyramid? There we go. So Mediterranean diet really is, you know, at its root, there are grains definitely, but, you know, lots of fruits and vegetables, lots of olive oil, fish and seafood, dairy, eggs, and poultry. Really, when we're talking about meat and dairy and eggs and all that stuff, generally smaller amounts of that. But really, I mean, it's really, really rooted in fruits and vegetables, lots of beans, peas, legumes, nuts, and seeds, not so much pasta all the time. But certainly that can be, you know, if you don't have celiac issues, that is not an unreasonable thing. Um, there is a book, a good friend and colleague of mine really wrote a great book called The Mediterranean Method. And that is a super reference in terms of explaining everything and the benefits of it, but lots of good recipes. And so that's, I have a couple of friends and patients that have actually bought the book that really like it. And that's something that I've found really helpful too. So maybe hopefully that helps answer that question a little bit.
Well, it does, but in working with the other diet that you gave me with the cardio metabolic, how
Yep.
do you balance that one with this? Do you just completely get
No,
rid of one?
Nikki, actually, that cardiometabolic diet and all the blue foods on there, that is very Mediterranean focused.
It's very similar.
Yes. So yeah, you have like with the Mediterranean diet, you definitely have you have like more of a focus. And so if you really focused on the blue foods on the cardiometabolic, those are going to be bigger keys for your Mediterranean.
Okay, thank you.
Yeah, you're welcome. Any other questions? Hopefully that's helpful. Okay. Well, you guys go have an awesome weekend. It looks really nice out, and according to the forecast, we should be good till Sunday. Okay. So, all right. Have a good weekend, everybody. Thank you.
Thank you.
Thank you.